I'm Dr. Eric Moore, head and neck surgeon at the Mayo Clinic, and I'm back with my patient Heidi, who's had a parotid gland tumor and parotid surgery in the past, and we're discussing issues regarding diagnosis, workup, management, and treatment of parotid gland tumors. Heidi, thank you again for joining us.
Thank you,
What's the next question?
So now that we've talked about preparing for your first visit, obviously there are certain diagnostic tests that are utilized to properly diagnose a parotid tumor. This can be very confusing to patients because there are so many tests that can be run, and it seems like doctors vary on which ones they choose. So could we talk a little bit about each test, and we can talk about what this test means and then what it's going to tell a physician?
Yes.
So if we start with an ultrasound, what is that going to tell you as a physician, and why would that be utilized?
So after the physical examination, many physicians want to get sort of a picture of that tumor somehow and a lay of the land, so to speak, as where's that tumor going? Is it coming out of the parotid gland? Is it involving other things? And so any diagnostic imaging test is some type of picture that we can acquire of that parotid gland tumor and look under the skin. Ultrasound is popular because ultrasound is readily available. Many physicians have ultrasound in their office right next to them and consider it part of their physical examination. And ultrasound is easy to undergo, meaning it doesn't require keeping perfectly still like some other imaging studies require the patient to do. It doesn't often require going in for a separate test. It's very quick. And it does give a good picture many times of the mass and the surrounding parotid gland. So why wouldn't everybody get ultrasound? One of the problems with ultrasound is it's a dynamic test. It's something that is almost like a physical examination. How you're performing it and what you're seeing right then is very important, and it's difficult to translate those images into something useful for somebody else to look at many times. And the images that are acquired are like taking single snapshots of a video, and so they don't often tell the whole story. And so ultrasound is difficult to get and then bring to another physician and say, hey, what do you think of this? Many times all they can tell is just what snapshots were taken, and is the mass solid? Is it full of fluid, meaning cystic? That's important sometimes. How big is it? What does it look like at its edge in the parotid gland? Ultrasound can tell you all those things, but ultrasound isn't often the most definitive test that people go to if they want a lot of information, because it's a little bit limited. It can tell you those things and not a whole lot else.
Okay, so I had a CT scan with contrast prior to coming to see you, and a lot of people seem to have that if they have a parotid tumor. So what is the CT scan with contrast going to tell you, and why is that utilized?
So a CT scan, in comparison to that ultrasound, I would consider it sort of an intermediate test along the way to all the different imaging studies that we can get. CT scan gives much more anatomic information. Many surgeons are very comfortable looking at the CT scan and interpreting all of the anatomy that they see in that region, so it gives them a very good roadmap. It tells them exactly the size and shape of the tumor, gives them a lot of information about is it solid, cystic, tells them a lot about the blood vessel supply to that tumor, tells about a lot about its interaction with the nerves, the bone, the blood vessels around the tumor. The one limitation of the CT scan is it's much better at blood vessels and bone and certain types of soft tissue than telling you all the different types of soft tissue. So I like the CT scan because it gives you a lot of anatomy information. It's relatively quick to acquire. It doesn't require the patient to lay still for a long period of time. It does have to be done frequently in a different facility than the physician's office. Most people don't have CT scanners in their office, so sometimes requires going to a different place. If it's going to be really useful, requires an IV to give contrast so that we can see the blood vessels. If you do the CT scan without contrast, it's very difficult to see the blood vessels. So it's a little bit invasive, more invasive than an ultrasound per se. And so a lot of information, a step up from the ultrasound in its invasiveness and time requirements, a little more costly than the ultrasound for payers, and then finally the ultimate far into that spectrum would probably be an MRI scan. So an MRI scan isn't a routine test that we order for parotid gland tumors most of the time because you don't need all that information. But if you have a very complex parotid tumor that you're trying to evaluate and you're saying, boy, the story, the exam has given me information that I think this parotid gland tumor is getting outside of the parotid gland, and I want to know more about the base of the skull, important blood vessels, nerves, muscles around there. MRI scan probably gives us the best picture of that, but an MRI scan requires Again, more specialized equipment, trip sometimes to a different room or facility, much more time requirement. To get a good MRI scan, people often have to lie within the MRI scanner very still so that the image isn't blurry for minutes at a time. And it can be anxiety provoking for people to be in that small space lying perfectly still with a relatively loud machine around them sometimes. So not everybody can undergo an MRI scan. And finally, there are limitations on MRI scans as far as other implants that people have placed in their body. Metal is not good in an MRI scanner, and so some people can't undergo an MRI scan because of things that they've had implanted with previous surgeries.
Okay, what about, so we talked about the CT scan and the MRI. There's also a PET scan. Can you explain what that is and why that would be utilized as opposed to these other two scans?
A PET scan is primarily, in our world, a scan that's used to evaluate malignant cancerous tumors. So PET scan is often combined with a CT scan as a two-part scan squeezed together into single series of images. The PET part of the PET scan requires putting in an IV, giving the patient a radionucleotide, so something that'll be picked up on a nuclear medicine scanner. It'll give off radiation for a short period of time,
Okay.
and that material is taken up in the PET scan by actively metabolizing cells. So the way I think about it and describe it to patients is that material is glucose or sugar. Those cells that are taking up that glucose and sugar will then take up a lot of the PET marker. They will then show up well on the PET scan, and those will typically be cells that are either cancerous tumors because they're quickly growing and metabolizing, or sometimes very inflamed or irritated areas because they're also quickly taking up the metabolite. So when you have a PET scan, it gives you a lot of information leading to the idea, is this tumor malignant or is it something I should be more worried about? So it's a step towards diagnosis. It can show you other things where places where that tumor is spread. So the PET scan will show you if that tumor has spread or metastasized to any lymph nodes or other parts of the body. But sometimes the PET scan gives you wrong information. Sometimes it's, somebody gets a PET scan, it lights up and they're worried, oh my gosh, I have cancer. It turns out they just have an infected tumor that's benign or had recent biopsy or something of that tumor that irritated it, and it will also show up on the PET scan. So we don't typically get PET scan as a first-line test. We use it often when we're convinced or at least concerned that this is a malignant tumor, but wouldn't get it for most parotid tumors because most parotid tumors are benign.
Okay, and so you've touched a little bit about biopsies that people may have had done, and obviously one of the main things that is utilized here is the fine needle aspiration or the fine needle biopsy. And a lot of patients are concerned about having that because our thought as patients is that if somehow this is disrupted while they're doing that test, then it's going to spread cells and then this tumor might come back. So what would you say to people who are concerned about having this test? And then can you explain what's actually going to happen when a fine needle biopsy is done?
Yes. So most of the time, when you have a parotid gland tumor, and we use the word tumor as a growth. So it could be benign, probably is benign because most parotid gland tumors are benign, or it could be malignant. It would be very useful to know as much information up front along those lines, is it benign or malignant, before you ever go about treating it. And so many people do a biopsy of the tumor to get that information. And the biopsy, and the simplest definition of a biopsy is you're taking out cells and putting them on a slide and having a pathologist interpret what they see and making a diagnosis. The least invasive way to take those cells out, causing the least harm to the patient, causing the least pain to the patient, and giving you the most information without undoing something going forward, without causing a problem going forward, is to do a fine needle aspiration biopsy. Fine needle aspiration biopsy requires numbing up the skin with a local anesthetic and then passing a little bit larger needle through the skin into the tumor and taking out cells in a syringe through that needle from the tumor and then placing them onto a slide, fixing it, staining it, giving it to a pathologist, and having them read what they see on that slide to make a diagnosis. There's several problems that can happen there. So for one, it's not always possible to feel the tumor. And it's possible to miss the tumor on the fine needle aspiration biopsy. So sometimes people need to have their fine needle aspiration biopsy in conjunction with an imaging study to make sure that the needle gets into the tumor and that you're biopsying the correct place. And most of that's done through ultrasound. Ultrasound along with the fine needle to ensure that you get the right cells out. Because if you just take cells out next to the tumor of the parotid gland, the pathologist will say this looks like normal parotid tissue, and everybody will be reassured this is normal parotid tissue, but that's a false biopsy. So you want to try to avoid a false biopsy. And specifically to address the question, does the fine needle aspiration biopsy rupture the capsule of the tumor and lead to spillage or spread or problem later? In general, no. Most people who do fine needle aspiration biopsy regularly feel confident in the fact that they're not going to disrupt the tumor with the fine needle, and that's the key, the fine needle, and not a huge bore needle that could rupture the capsule. And so most fine needle aspiration biopsies are done with a small enough needle that you can go through the capsule without spilling tumor outside that capsule and disrupting the care going forward and get an adequate sample. And more than 90% of the time, if done by someone experienced, that goes well. There are some pitfalls. You could miss the tumor. You could get non-diagnostic specimen. You could cause bleeding into the tumor. You could cause irritation or infection in the tumor. Most people who go through a fine needle aspiration biopsy will say, oh, for a week after that, my tumor was bigger. It felt like it grew. It was much more prominent. I was painful. That's irritation, the body reacting to the fine needle. Usually that's not a huge problem, but sometimes that is a problem. Sometimes we find after a fine needle aspiration biopsy has been done, a lot of irritation happens, that tumor becomes kind of sticky and a little bit more difficult to take out. Why does the confusion come up? The confusion comes up is because, unfortunately, not every place does everything the same way. Maybe that's good. Maybe certain places are much better at doing this than this, and so they've gravitated towards this works well for us, and we do it this way, and over here this works better. But variation, I think, causes people anxiety. Why are they doing it this way here when my friend had it done differently this way over here? And the best way I can explain that variation is that different practices have evolved to utilize different skill sets in different people, and they develop confidence in that pathway and then predominantly use that. We, for instance, use very little fine needle aspiration biopsy because most parotid gland tumors need to be removed. We have pathologists in the operating room with us, what's called frozen section pathology, where they can evaluate that very accurately, very quickly. Not every place has that army of pathologists with them to make that diagnosis. So we feel like we're going to go to the operating room, not do a biopsy that could potentially irritate the tumor a lot of times or make it sticky, and most of the time just go in, take it out, give it to our frozen section pathologist, have them confirm it's a benign tumor, or no, it's not, it's a malignant tumor, and then adjust accordingly on the fly. Now that requires us having a conversation with the patient and saying we might do this, and gaining confidence that we're going to do the right thing, but that works well in our hands. But my best friend over at another institution is also a great surgeon, gets great results, might fine needle aspiration biopsy all the time because that pathway works well for him, and that's how he gets the most accurate diagnosis before going to the operating room.
Okay, so you talked a little bit about how the reasons why a biopsy might miss the tumor. Some of these other scans that we talked about a little bit earlier, are there reasons why those could potentially be missed on a scan? And if so, like why would that be missed?
Well, some tumors are more obvious than others on scans depending on their size, consistency, location. Some tumors that might be very easy to feel because they're so close to the surface of the skin, but they're only a couple millimeters in size, might be overlooked on a scan. There's human error in reading the scan. The scan doesn't necessarily miss the tumor, but the person interpreting the scan might miss the tumor. So it depends very often on is the tumor showing up well on the scan? Is it big enough to see on a scan? Is the person reading the scan knowing sort of what to look for and reading it correctly? All those reasons are why you could potentially have a scan. And this doesn't happen very often, but I've seen it happen where the scan report comes back fine, but there's actually something there. So that's how you could miss it on a scan. Some tumors fluctuate a little bit in size. There are some cystic tumors that will get bigger and smaller, and they might be very prominent one week and then a little bit smaller maybe after they settle down and they're less inflamed, or a biopsy's been done and they sucks all the fluid out of them or something like that, where they could potentially be missed on a scan.
You mentioned earlier with the ultrasound that if, it's hard for another physician to have to interpret the results of that. So there are times when patients are sent for additional testing. And the fact that they're sent for additional testing is very concerning to a patient. And it makes, all of us, it's human nature to say, like, well, I'm probably being sent for testing because I have cancer or there's some other problem that they're not telling me. So what are the reasons why additional tests would be required prior to having surgery?
I'm glad you brought that up, and I've got to say that I learned that the hard way, and I apologize on the behalf of surgeons and medical community that we don't always think we're ordering another test to get information, and that might be extremely concerning to the patient. And it's become a little bit more of a problem in this era of readily available medical information that this isn't supposed to happen. We try to guard against this, but you might get scheduled for an additional test before you've had the opportunity to speak with a surgeon about why that's being so, and then sit there in that period of anxiety about why is this being done. Most of the time, an additional test is being done because the original test didn't give us enough information or the information that we were looking for. Not necessarily that we're more concerned. We try to use every test with a purpose. We order a test because it's going to do something useful for us, but that doesn't necessarily mean worth assuming the worst or thinking that something's bad, just that we need more information to move forward. So I think ultrasound is probably the perfect example of that. Ultrasound is a great test in the hands of the right person because it's very user dependent. CT scans, MRI scans are also user dependent. That's why people train to be able to deliver these tests and get good quality out of them and things like that. But ultrasound very much comes down to the knowledge and the skill and the expertise of the person doing it and what they interpret. And the images, like I said, are a little bit harder to translate. So many times when people come in with an ultrasound and I'm confused by the report or it doesn't add up or something like that, and they bring me some images and they don't give me that roadmap, I might order an additional imaging test just to get some more information.
Okay. So all of these tools that we've talked about and these diagnostic tests are all great assets in terms of being able to give you as much information as possible to diagnose a tumor. However, I think we've talked before that none of these tests are going to be 100% accurate, especially with respect to like the fine needle aspiration. So if somebody gets a fine needle aspiration and it comes back and says this tumor is benign, what is your advice for people who then think, I don't need to do anything about this tumor because it's benign and the surgery is scary and I don't want my face to be paralyzed, so I'm just going to wait. Yeah. What is your advice to those people?
Yes. So first, let's talk about how could the fine needle aspiration be wrong. Right. The fine needle aspiration is correct if done properly and read by an experienced pathologist more than 90% of the time, but the parotid gland is still a little bit more difficult to interpret for the pathologist on fine needle aspiration biopsy than other types of tumors in other areas. So it's not a slam dunk that the fine needle aspiration biopsy is going to be absolutely what the tumor is. We see this in both directions. Benign tumors called benign on fine needle aspiration biopsy ending up being malignant tumors. They didn't turn into a malignant tumor. They were a malignant tumor and the fine needle aspiration biopsy was incorrect. That happens occasionally. And we see it the other way around. Malignant tumors, cancers, being called malignant on the fine needle aspiration biopsy and actually being a benign tumor. And so you can't rest on the fine needle aspiration biopsy and say, I'm not going to do anything because it's benign in the vast majority of cases. It can be reassuring that the fine needle aspiration biopsy is benign, but parotid gland benign tumors still go on to cause problems, and this is the misconception. It's not a malignant tumor. Malignant means it's going to potentially metastasize or jump somewhere else. The benign tumors don't do that in almost every circumstance, but they still need treatment, and that's the misconception. Benign doesn't mean do nothing. And the reason benign doesn't mean do nothing in parotid gland tumors is that the benign tumors will grow. Nobody wants a very large tumor on the side of their face, and that's what can happen after several months or years ignoring a tumor. Or in a small percentage of circumstances, they can transform and become malignant. And for that reason, unless people are in such poor health or have circumstances that make the very act of surgery worse than the act of observing the potentially benign tumor, we recommend to most people, almost everybody, even though you have a benign tumor, that's not emergent. That's reassuring that it's benign, but you should still treat it. and do something about it, because it could very likely cause problems later.
So is one of those problems potentially that the benign tumor could grow so large that, perhaps it gets tangled in the nerves or it makes surgery more complicated down the line should you wait?
We see every now and then somebody with just a very large parotid gland tumor on their cheek that has slowly grown over years to become this very large mass. And the stakes go up in removing such a large mass. The surgery becomes more difficult technically and sometimes can become more risky. So we encourage people not to get to that point. That's not common. Most of the time the tumor starts out small. People either get some advice where they should observe it because it's benign, which we disagree with, or they just decide that they're not going to seek treatment because they're concerned about the risks of those treatment, and the tumor gets bigger. Even a inch in diameter, 2-inch in diameter tumor, which is a large parotid tumor, is still very removable and still very safe to remove in the right hands. So it's not that it can't be removed, or even that it can't be removed with a good outcome, but it's almost always easier when it's smaller.
Okay, great, thank you.